Okay. Assalamu alaikum. Good afternoon, everyone. Welcome to the Ahsan Rashid Memorial Session. This is one of our most eagerly awaited and most popular sessions in the symposium. In this session, what we do is we select the best original research submitted to the symposium this year. And as you may know, we had over 384 abstracts submitted this year. Of those, the scientific committee chose what they felt were the 6 best studies for presentation in this session. We have a panel of distinguished judges who will judge each of these presentations. Each presenter will have 8 minutes to present, followed by 2 minutes for questioning. We are quite strict on time. A few words about the person that this session is named after. We have the picture back up. I can see it over here, but not over there. There we are. So Mr. Ahsan Rashid was a great supporter and benefactor of the Shaukat Khanum Memorial Trust. He was a chartered accountant by training, and he worked in finance all over the world. He was a close personal friend of our chairman and founder, Mr. Imran Khan, and he was prominent in philanthropy and later in politics. He was a very popular figure amongst the expatriate community in the Kingdom of Saudi Arabia, and that's where he first started to help Imran Khan with fundraising for the hospital, including at some very difficult times when we were short of funds early on after the commencement of functions at the hospital. He was later also involved in politics. Unfortunately, he himself developed cancer and passed away as a result of that at the end of 2016. He's greatly missed and, as I said, was a great friend and supporter of the hospital. In 2017, in honor of his memory and his contributions to the hospital, we asked his family if they'd be interested in helping us in establishing this award for the highest ranked research paper presented at this symposium each year. And we're honored today to have his son with us, as well as his brother, Brigadier Naeem Ahmed. And at the end of the session, they will come up to present the prize to the winner. So we'll go on now to invite the judges up onto the stage. And in no particular order, we have Professor Muzaffar Kizilbash. I'd like him to join us on the stage here, please. Professor Kizilbash is Professor of Medicine and Head of Myeloma Transplantation and Cellular Therapy at the University of Texas MD Anderson Cancer Center in Houston in the United States. As you know, he was the plenary speaker for this year and spoke yesterday at the plenary session. Next, we have Professor Jacek Gronwald, Professor in Genetics and Pathology at the International Hereditary Cancer Center at the Pomeranian Medical University in Poland. Thank you. And last but not least, we have our very own Dr. Amna Hassan. Loud applause, especially from her own trainees in the second row, I see, but that's very good, very good. Amna is a consultant in nuclear medicine at Shaukat Khanum, Lahore. And we will now start with the first speaker, which is Sayyida Maryam Zahra Naqvi from Shaukat Khanum Cancer Hospital in Lahore. She will present her study entitled Analgesic Efficacy of Erectospiny Plain Block versus Retrolaminar Block in patients undergoing major oncological breast surgery. This is a randomized controlled trial. So once she's up on the stage, then we'll start the clock. Okay.
Bismillahirrahmanirrahim. Whoever saves a life, it will be as if they have saved all of humanity. This verse from Quran deeply inspires me. Ladies and gentlemen, Assalamu alaikum. I am Dr. Maryam Zahra, third-year resident in the Department of Anesthesia and Pain Medicine at Shaukat Khanum Hospital. Today, I will be discussing the analgesic efficacy of erector spiny plane block versus retrolaminar block in patients undergoing major oncological breast surgery based on a randomized control trial. I have no conflicts of interest to declare. As we all aware, breast cancer is the most prevalent cancer among women globally. In US, the lifetime risk of women being diagnosed with breast cancer has increased significantly. Previously, this was 1 in 11 women, but now it has risen to a stark 1 in 8 women. Tragically, every 13 minutes, a single woman dies from breast cancer. This map highlights the increasing mortality of breast cancer patients globally. If you look at Pakistan's Globocan data from 2022, 185,000 new cases were reported annually, and Shaukat Khanum Hospital alone performed 700 breast surgeries by September 2024. Let's take a brief pause to ponder this fact. 700 surgeries and the year is still ongoing. Breast cancer can be treated using various modalities. However, surgery remains the mainstay. As anesthetist, pain optimization during the perioperative period is of paramount importance. Acute post-surgical pain occurs in 30 to 50% of the patients. But why we are so much interested in acute post-surgical pain? Because if left untreated, it can progress to chronic pain, with women undergoing mastectomy often experiencing a higher peak pain intensity. And this chronic pain destroys the quality of life. Even after the patient is rid of the cancer, the chronic pain still lives there. A meta-analysis of 187 studies revealed that almost half of all women undergoing breast cancer surgery develop persistent post-operative pain. Ladies and gentlemen, I would like to take a moment to emphasize this fact, how significant this number is. In pain optimization, a comprehensive approach includes non-pharmacological therapy, and interventional techniques. Within the pharmacological framework, we generally adhere to WHO analgesic ladder, starting from simpler opioids and then progressing to more interventional advanced techniques. This is where the innovative research from our department plays a crucial role. Today, from various techniques, I will be discussing the erector spiny plane block and retrolaminar block. The rationale of this study is grounded in previous research comparing the analgesic efficacy of both blocks. However, previous studies have fallen short of providing evidence to determine one superior over another. The objectives of study is to compare total opioid consumption with the numerical rating scale and total opioid consumption in perioperative phase. We included adult female patients aged 18 to 60 years of age with ASA 1 and 2. However, patients with BMI more than 35 and undergoing bilateral breast surgery were excluded. This study was conducted at Shaukat Khanum Hospital during this period, and its design was a randomized control trial enrolling a total of 74 patients with 37 patients in each group. After standard anesthesia induction, one of the two blocks was administered to each patient accordingly. This ultrasound guide, this slide shows the ultrasound-guided depiction of retrolaminar block with the target being the lamina, while subsequent slide illustrating the similar anatomy for erector spiny plane block in which we place our needle at transverse process. The injectate we used was bupivacaine along with dexmedetomidine. Moving on to results, 29 patients out of 37 patients in each group reported no pain. 2 hours post-surgery, 29 patients receiving erector spiny plane block and 30 patients receiving retrolaminar block reported no pain. On arrival to PACU and 2 hours post-surgery, mild to moderate pain was noted in few patients. You can see the numbers with significantly lower and nearly identical in both groups, yielding a p-value that is not statistically significant. In terms of morphine consumption, 15 patients in each group reported no pain. However, during intraoperative phase, the patient receiving erector spinal plane block exhibit a slight increase in morphine intake. While post-operative phase, the morphine consumption aligned closely between the both groups. Ladies and gentlemen, the final figures speak for themselves. There was no significant difference between the pain score levels and opioid consumption between the two blocks. Let me show you how this work is changing the game. Nearly half of all patients had managed their pain with the regional technique alone, which is a notable finding and highlighting the effectiveness of this approach. This regional technique decreases patient dependency on opioids, gives better quality of life, and multiple evidence from retrospective studies shows that this technique decreases metastasis. From hospital perspective, this technique reduces patient burden, alleviates the strain on healthcare system, and as we are an opioid poor country, so these techniques help medication conservation. The strength of this study lies in its design as a randomized control trial with clearly defined outcomes and local relevance, addressing the specific pain management needs in our population. However, it is a single-center study with limited follow-up period. Conclusively, erector spinal plane block is comparable to retrolaminar block in terms of post-operative analgesia, which is incongruent with the international data given in literature. And these techniques decrease the opioid consumption, thereby sparing the patient from side effects associated with opioids. Ladies and gentlemen, let's all strive together for the basic human right. Let there be no pain to anyone. Thank you.
Thank you, Dr. Mariam. So this paper is now open for questions.
Thoracic epidural and paravertebral blocks are also an option. So why we are not using them? And as your studies show similar results between retrolaminar block and erector spinae block. So what do you think clinicians going to prefer?
Thank you. That's a very relevant question. Actually, paravertebral block and thoracic epidural was used previously. But considering their complications, now we are urinary retention, hypotension, nerve block, nerve damage, and pneumothorax. So now clinicians are preferring these techniques more. And considering the ERAS pathway, after these blocks, we can discharge our patient as a day case. And in both blocks, as in our study, I have not encountered any complication. But if you look back on the literature, then after erector spinal plane block is more safer, as chances of complications is less in erector spinal plane block, and it is easier to perform. And the studies shows that it has longer post-operative analgesic effect. Thank you.
Hello, hi, great effort, Mariam. I just have one question. There was this reference that you've shared from it was a very similar previous study. How does your particular study stands out? What is it about your study that's kind of contributing to the literature?
Thank you. That's a very good question. Previous studies are available, but every population reacts differently. So this needs to be done in our population also, because it can vary the results. And in previous studies, we have used levobupivacaine, bupivacaine, and ropivacaine. But in this study, we have used dexmedetomidine as an adjunct, so making it a little bit different. And the previous studies was focusing on mostly VAD surgeries and multiple rib fractures, and has a little emphasis on breast oncological population. So my study is different in this way. And additionally, this study can also can also, this also helps the medical practitioner to choose any of these blocks because both have similar efficacy.
We have time
Thank
for
you.
one more quick question, please.
So we could see that there was no clinical significant difference between two therapies. How would you respond that was your therapy, your chosen therapy, was cost efficient and time efficient?
Ji. In terms of, thank you so much. In terms of time efficiency, if we have arranged the ultrasound and the proper medication which we require beforehand, then this technique is also time effective because we have seen the total induction in time using these blocks is as little as 7 minutes. So it is time effective. In terms of cost effective, because we use opioid morphine usually, and morphine is available in our country with difficulty. So in this case, these techniques can be used, and this is cost effective in that way. Thank you.
Thank you. Thank you, Dr. Mariam. Okay, so the next talk is entitled Genetic Insights and Diagnostic Challenges in Bone Marrow Failure Syndromes, Experienced from a Low to Middle Income Country. It's a pleasure to welcome Dr. Syed Ibrahim Bukhari from the Aga Khan University Hospital in Karachi to present.
Hello, Assalamu alaikum everyone. Hope you are all doing well. I am Dr. Syed Ibrahim Bukhari, currently a fellow in pediatric oncology program at Aga Khan University Hospital, Karachi. So the topic of my presentation today is genetic insights and diagnostic challenges in marrow failure, a comprehensive study in a low to middle income country. These are my co-authors, and Dr. Sadaf Altab was the senior author in my study. So I have nothing to disclose. So I will start with what is a bone marrow failure. So basically, bone marrow failure is inability to produce one or more blood cell lineages, and this can be either primary or secondary. If it manifests at a hematopoietic stem cell level, it will lead to upfront pancytopenia. If it manifests at a later developmental stage of stem cell development, it can lead to single cell cytopenias, and it will always have propensity to progress to full-blown pancytopenia. So there are three main categories of aplastic anemias that we see routinely in our clinical settings. The first is inherited bone marrow failure syndromes. Second one is aplastic anemia or acquired aplastic anemia, and the hypoplastic myelodysplastic syndromes. So why the need of this study and why so much emphasis on genetic testing? So inherited bone marrow failure syndromes, they basically arise from a pathogenic variant or a likely pathogenic variant in a specific genes. And we see the ancillary testing like chromosomal breakage and telomere length shortening, they are not always diagnostic. They can be quite misleading. And the most important thing, inherited bone marrow failure syndromes have the propensity to progress to MDS and ultimately acute leukemia. So that is a very important thing that we have to keep in mind. On the other hand, myelodysplastic syndromes can present as hypercellular, normocellular, or hypocellular marrow findings on biopsy. So if it presents as hypercellular or normocellular finding and we can clearly see a dysplasia in the marrow, then we are okay. But if it presents as a hypocellular marrow or pancytopenia, then the marrow will only show a aplastic marrow. It will not show as dysplasia. And as we know, MDS can progress to acute myeloid leukemia. So again, this diagnosis is very, very important. Like I said, in all three cases, bone marrow will only show a hypoplastic marrow. Also, the genetic testing has implications for family members. There might be family members who are currently asymptomatic, but they are carrying the pathogenic gene, and they can have a need of ongoing monitoring because they can develop the clinical phenotype at any time. Also, there is a difference of treatment between these three categories. For inherited bone marrow failures and myelodysplastic syndromes, the literature clearly states a need for upfront transplantation for a curative treatment. While for an acquired aplastic anemia, the first line again is hematopoietic stem cell transplant only if there is a matched sibling or matched related donor. Otherwise, we can opt for immunosuppressive therapy. And then second line, we can use a hematopoietic stem cell transplant from a matched unrelated donor. And now studies are also coming up for haploidentical transplant. So because of all these reasons that I have discussed above, now the genetic testing is a standard of care diagnostic test for these patients in many high-income countries. This can be performed via different techniques like next generation sequencing, target panel testing, whole exome sequencing, and whole genome sequencing. The costs have considerably become low over the past few years, but still it is very high for a low middle income country like ours. So what we did, we started doing genetic testing for every patient who presented to us with a plastic marrow from January 2020 onwards. And we sent all these tests because these tests are not available in Pakistan. So we sent these tests abroad in various clinical laboratories. So this was a cross-sectional study conducted at Department of Oncology, Aga Khan University, Karachi. And we included eligible subjects from January 2020 to January 2024. This was a non-probability consecutive sampling, and the total sample size was 40. So my data included 21 males and 19 females. The median age of diagnosis was 8 years. All presented to us with aplastic anemia, and the marrow showed hypocellular marrow. In 12 of these patients, we found pathogenic variants in different genes. 15 had variants of uncertain significance, while 13 did not show any genetic mutation. Among those who had 15 variants of uncertain significance, 3 were clinically positive. How? All 3 had a clinical phenotype of an autosomal recessive disease, but the genetic testing only showed a heterogeneous mutation, in contrary to what we expected, like compound heterozygous or a homozygous mutation. These are the genes which we detected. The most common was FENCA gene, which is consistent with Fanconi anemia, followed by MPL. So the 21 patients were initially diagnosed clinically as idiopathic aplastic anemia. Among them, 3 had mutations for Fanconi anemia, 1 had mutation for congenital A megakaryocytic thrombocytopenia. 2 who were initially diagnosed as MDS, 1 had Fanconi anemia, stating that this was basically Fanconi anemia which had progressed to MDS. 3 patients who initially had presented with isolated thrombocytopenia. 1 was found to have congenital A megakaryocytic thrombocytopenia. 1 was found to have Schaumann-Diamond syndrome. 1 was found to have dyskeratosis congenita. Another important thing was 6 patients who had pathogenic variant for Fanconi anemia. Only 3 were positive for chromosomal breakage. 3 were negative for chromosomal breakage. So all in all, 40 patients were tested, 12 genes were identified, and diagnostic efficacy was 38% in our study. So to conclude my findings, 11 genes were identified in varied population of Pakistan and 12 patients. And diagnostic efficacy was 33%, which is comparable to the data from the West. Proper diagnosis helped in making upfront decision for transplant. It also helped foreseeing the prognosis for those patients. And the diagnostic testing, which was extended to family members, offered selection of proper donor for transplant. Like if a sibling who is clinically well, but is also carrying the same mutation was not a donor for transplantation, of course. And we also identified 15 variants of uncertain clinical significance. These might later on add to diagnostic variants among Asian population because the data on the genome that we have is all from the Western population. And we are obviously a diverse population from low middle income country with a lot of consanguinity. So this might add to all the genomic data. So these are my references, and that was all about my presentation. Thank you.
Thank you, Dr. Ibrahim. So this paper is open for questions from the audience or from the judges.
Can I? Someone is coming on.
Well done, Dr. Ibrahim. So my question was regarding number 1, cost. What was the cost for these patients? And then when you said that you extended the testing if it was tested positive to family members. I mean, did you find that you found new variants in family members without a family history? Was family history at all helpful for you in that situation? Because I'm assuming that when you sent the testing, you already had identified maybe some potential inherited disorders in these patients. So how did that help you?
Yeah, so to answer that question, so in almost all of the families that we see an autosomal recessive disorder. So in all of those, we send genetic testing on all the siblings who are potential donors for transplant, and almost in all of those families, we found a mutation in one or two of the siblings. So this and when we extended the testing to to parents as well, so we also found like a single mutation in those which were not clinically positive. And understandably, there was no clinical symptoms, but because of a lot of consanguinity in our population, this was expected that the clinical phenotype will be visible in the upcoming generations.
And just one, do we have time for another question? Yeah, good. There are a lot of ethical considerations when you send genetic testing for familial disorders. How did you deal with that issue in your research? Like, did you take specific consent highlighting the potential, implications of finding an inherited disorder? And then how did you break the news to families and provide them with the necessary genetic counseling and screening that they need for their inherited disorder?
Yes, so that's a very good question. And fortunately for us, many of the patients actually are referred from other centers, and they actually already have a little bit understanding about the diseases. But anyways, we always have our ethical team on board with us. We break the news to the family with all the considering all the ethical concerns. And uh, I think I remember only two of the families who actually refused for testing for their extended family members. All other were actually grateful that we have informed them about the possibility of the disease in the other siblings, and they actually asked for us to go for it.
Okay, thank you.
Dr. Kizilbash. No?
Okay.
Thank you.
Thank you very much. Okay, so our next presentation is entitled Extranodal Extension. I'm sorry, that's the next one. So this presentation is entitled Comparison of Patient Satisfaction in Postoperative Breast Surgery Patients Having a Physical Clinic and Teleclinic Follow-up. This is a randomized controlled trial, and to present it will be Dr. Mohammad Awais Kaval, Shaukat Khanum Memorial Cancer Hospital, Lahore.
Thank you, Dr. Ahsan.
Thank you.
So my name is Mohammad Awais Kaval. I'm from the Department of Surgical Oncology at Shaukat Khanum, Lahore, and I'll be presenting our study PSPVT trial. So I don't have any conflict of interest to declare, and no funding was sought or received for this study. So as we all know, breast cancer is on the rise, and it's most commonly diagnosed cancer worldwide. The worldwide incidence in 2022 was 1.9 million. The same year in Pakistan, we diagnosed 30,682 new breast cancer patients. This highlights the significant burden this disease continues to place on our country's healthcare facilities. Breast cancer incidence in Pakistan is projected to be doubled by 2050, and incidence is projected to be as high as 65,000 per annum. So teleclinics, which became popular in the wake of COVID-19 pandemic, have been instrumental in improving healthcare delivery in breast surgery patients. Patient satisfaction is increasingly becoming a focal point in clinical research, and it all starts by caring enough to engage the patient in decision making. Patient satisfaction is a subjective measure of the healthcare journey, capturing how well the experience meets the patient's expectations, fulfills their needs, and resonates through the care they receive. So I'm a big Sherlock Holmes fan, so I'll quote him. So he says, it's a capital mistake to theorize before one has data. So this study aims to address the limited evidence on patients' perceptions of telephone consultations. So the primary outcome measure of this study was patient satisfaction, and it was measured using patient satisfaction questionnaire PSQ-18. Formal permission was taken from the RAND Corporation regarding use and translation of this validated tool. PSQ-18 comprises of 7 dimensions of satisfaction with medical care. It includes general satisfaction, technical quality, interpersonal manners, communication, financial aspects, time spent with doctor, and accessibility and convenience. As a secondary outcome measure, we also recorded number of emergency assessment room visits, number of emergency phone calls, and post-operative complications. So this was the English version of the questionnaire that we used, and this was the Urdu version of the validated tool that we used. So this was a single-blinded randomized controlled trial. Patients were randomized either into the physical clinic or into the teleclinic after 2 weeks after surgery, and they were followed up after 1 week in a satisfaction interview at the time of convenience, and the assessor was blind. So all the breast cancer patients from 18 to 70 years of age who were undergoing breast cancer surgery as a part of their treatment were included in this study. And patients who were less than 18 or more than 70 years of age who were undergoing palliative surgery or were undergoing reconstructions or had a chronic pain were excluded from this study. So this trial was registered on clinicaltrials.gov. A clinical trial identifier was issued, and the protocol was published and was available to the public before commencement of the study. This was also shared with the volunteers who were participating in this study. So we calculated sample size to be 184, considering 95% power, 95% confidence interval, and 80% power, and including 10% dropout rate. The final sample size was 202. So 260 patients were assessed. 245 were invited to participate after the application of inclusion and exclusion criteria, and they were randomized into 101 into each group. So this was a randomized controlled trial, but even then we retrospectively analyzed our baseline characteristics just to make sure that we don't have any biasness in the study. So as you can see on the first column, there is the characteristics, and then the last column, there are the p-values. There's no significant p-value, which indicates that randomization is correctly done, and it also will validate our results. So this was our primary outcome measure, patient satisfaction. So as you can see, general satisfaction, the p-value is non-significant. Technical quality, again, a non-significant p-value. And interpersonal manners, again, non-significant p-value. Communication gives us a significant p-value. The patients felt better communicated in the physical clinics in comparison with the teleclinics. Financial aspects, again, non-significant p-value. Time spent with doctors, non-significant p-value. Accessibility and convenience, non-significant p-value. So we also ran a multivariate regression analysis just to make sure if there is any other variable which is affecting the patient satisfaction. And we found out two. That's the beauty for randomized control trial. So we found two: emergency visit and postoperative complications. And then we just made sure that they were comparable in both groups. So the emergency visit had a positive effect on the general satisfaction. It might be related to the more number of patients visiting and meeting the healthcare providers. Emergency phone calls and emergency visit in both the tele and the physical clinic group were comparable. Similarly, postoperative complications in the both arms were comparable, but they had a negative effect on the general satisfaction. So teleclinics and physical clinics are comparable in terms of general satisfaction, technical quality, interpersonal manners, financial aspects, time spent with doctor, accessibility, and convenience. Postoperative complications were comparable in both groups, in teleclinic and in personal visits, providing valuable data on effectiveness of telehealth. And we also identified area of improvement, which was communication. So this is a single-centered study. Results may not broadly apply to other institutions with different patient demographics. While this study highlights communication as a key area for improvement, it may not fully account for the complexities of remote communication that can impact the quality of care provided in teleclinics. So a well-conducted randomized controlled trial like this PSPVT trial gives us something as close to truth as we can get in science. This is not just research for research's sake. It is about understanding what matters to our patients, finding clarity in complexity, and laying a foundation for healthcare that is as reliable as it is compassionate. Thank you for joining me on this journey through PSPVT trial, where we saw firsthand the beauty and power of a properly conducted randomized controlled trial. I hope this study inspires us all to keep asking questions, refining our methods, and seeking truths that serve our patients and the world of medicine alike. Thank you.
Thank you, Dr. Aves.
Thank you.
So this paper is now open for questions.
So thank you for your talk. We belong to a country with a different literacy rate, and unfortunately, when we're seeing such patients in our clinic, when we ask them about the surgery, they feel that all is good. But when we examine them, there is a lot of seroma, discharges, and wound dehiscence. So with such literacy rate in our country, how do you examine, or what measures have you asked, or what kind of question you ask from those patients to assess these complications, which are very common in breast surgeries? Thank you.
So two things. First of all, I would like to point out to the data. So there were comparable postoperative complications in both groups, and we recorded them up to 6 weeks. And then there were comparable emergency visits and emergency phone calls into both groups. So of course, there are problems with the telehealth, but the main issue that our study was trying to address was the patient satisfaction. Right, and we believe that the patient are actually satisfied in the both groups. And of course, physical clinics has its own merits and demerits, and telehealth has its own merits and demerits. But coming from a patient point of view, they believe that they had equal level of satisfaction in both groups. And if you look in detail in these results, like for example, let's talk about financial aspects. Patient had a very high level of satisfaction in the financial aspect in the teleclinic group, because it's a subjective thing. If somebody is, if a financial aspect matters for someone, he would give a very high patient satisfaction in that group. But the variability and the standard deviation made it non-significant. So all this was very subjective, and this study actually tries to tell the story from the patient side. Yeah, I hope that answers you.
Lovely study, I must say. But I seek your clarification on your intervention. So what I understood that you have just changed the format, like the consultation through physical clinic versus using teleclinic.
Yeah.
So I just see the
So this
digital
was not
aspect.
an intervention trial. This was basically a non-inferiority trial.
Okay.
So we're trying to compare both arms, if one arm is superior to the other, or if one arm is inferior to the other. So this was a non-inferiority trial. So the results are that both are comparable.
Yeah, but they also have intervention in those kind of trial. But I think you use the format, change of format, right?
No, so the thing is that, so first of all, we were using both of these as a hybrid model when the study was conducted. So if you are doing two things and you just want to compare those two, and there two things are already happening, you won't name it as an intervention or as a control. If you are comparing two arms, two things that are already happening, then it would be either a superiority trial. You'll try to prove that one arm is superior to another, or you will try to prove that one arm is not inferior to another. So what we tried was, this trial was calculated as a non-inferiority trial. So we were trying to prove that the physical clinics and the teleclinics, both arms are comparable, and the teleclinic is not non-inferior to the physical clinic. I hope that answers.
Thank you, Dr.
Thank you.
Vess. Are there any other questions? If not, then thank you very much.
Thank you.
Okay, and now we have the next speaker, extranodal extension in papillary thyroid carcinoma, assessing its impact on recurrence risk and clinical outcomes. And to present this, we have Dr. Muntaha Fatima Rana from Shaukat Khanum Memorial Cancer Hospital, Lahore.
Assalamu alaikum and good evening, everyone. I, Dr. Muntaha Fatma Ana from Department of Nuclear Medicine, feel privileged to present my study entitled Extranodal Extension in Papillary Thyroid Carcinoma, assessing its impact on recurrence and clinical outcome. I have no disclosures. This is the brief layout of my presentation. As we all know that papillary thyroid carcinoma is the most common type of differentiated thyroid cancers, accounting for approximately 80% of all thyroid neoplasms, with a predominant lymphatic spread. Amongst various cancers, thyroid cancer has the best overall prognosis with a lifetime recurrence of up to 30%. Extranodal extension is the extension of tumor cells beyond the nodal capsule into the perinodal fibroadipose tissue. It is a well-known poor prognostic marker for various cancers, but has not been adequately addressed in literature for thyroid cancers. Risk stratification is very important to estimate prognosis and to guide appropriate therapy, which in the case of thyroid cancer is routinely done based on American Thyroid Association guidelines. This guideline stratifies patients into low, intermediate, and high risk of recurrence based on histopathological parameters. As you can all see, it incorporates only two lymph node criteria, which is the number of lymph nodes involved and the size of largest metastatic nodes. However, extranodal extension is not addressed in any of these categories. Looking into the NCCN guidelines for management of thyroid cancer, even there is no consideration given to extranodal extension when addressing nodal involvement, which brings us to the objective of my study, that is, to evaluate the impact of extranodal extension on recurrence in papillary thyroid carcinoma. It was a retrospective study, and we collected data from January 2015 to December 2020, and we followed the patients till October 2024. All the patients were biopsy-proven patients of papillary thyroid carcinoma, and they were further segregated into two groups. One group having nodal disease with extranodal extension, and the other having nodal disease without extranodal extension. And they were followed up with a median follow-up of 5 years. We looked into the demographics and the histopathological parameters of tumor and the lymph nodes. The treatment that was given, recurrence was classified based on 3 criteria: biochemical recurrence, that included elevated tumor markers, the biopsy-proven recurrence, and the radiological recurrence, including conventional radiology as well as molecular imaging that includes PET scan. Coming to the results. A total of 97 patients were retrospectively evaluated, having a mean age of 35 years, and 58% of them were females, rest were males. Out of the 97 patients, 50 patients had nodal disease without extranodal extensions, and 47 patients had nodal disease with extranodal extension. And there were more females in both the categories as well. Looking into the number of lymph nodes involved, we see that a higher number of ENA positive group had more than 5 nodes involved, in contrast to ENA negative group who had less than 5 nodes involved in more patients. When we analyze the data in the light of higher risk features as guided by American Thyroid Association guidelines, we see that the extranodal extension positive category had more patients with high risk features in contrast to ENA negative group. And of the 47 patients in ENA positive group, 20 patients had recurrence, and out of them, 11 patients had only extranodal extension as a risk factor, and the rest of the 9 patients had other high risk features in addition to extranodal extension. And of the 50 patients in ENA negative group, 18 patients had recurrence and 15 patients had only nodal disease, but the rest of the 3 patients had other high-risk features in addition to nodal disease. So when we excluded high-risk patients from both the categories, we see that a substantial percentage of ENA positive group had disease recurrence. Calculating the odds ratio, which suggested that the odds of having recurrence were 32% higher in ENA positive group as compared to ENA negative group. Looking into the literature, this study conducted by Kim et al., who looked into the impact of extranodal extension on risk stratification, states that presence of extranodal extension confers an intermediate risk of recurrence, and it should be incorporated into the system for more accurate decisions. Another study looking into the prognostic implications of extranodal extension in papillary thyroid carcinoma also highlights that it is associated with worse prognosis, and it identifies poor risk patients more accurately. Many other studies evaluating the impact of extranodal extension on recurrence in papillary thyroid carcinoma also highlights its importance and labeled it as a significant prognostic marker. Despite this, ENE is yet to be addressed in ATA and NCCN guidelines. These were a few limitations of my study. Although I had a small study population, but we took a very defined study population of PTC patients having nodal disease and extranodal extension. And as we all know, although thyroid cancer is the most common endocrine cancer, but it has low incidence and high long-term survival, making prospective studies a bit difficult. To conclude, extranodal extension is not only linked to high incidence of high-risk disease, but it is a significantly a potential risk factor in its individuality. And extranodal extension should be considered an important risk factor when stratifying patients of papillary thyroid carcinoma regarding appropriate treatment and risk of recurrence. And mounting the evidence of my reference studies on top of my results, we hope to see this factor addressed in major thyroid cancer management guidelines. Thank you for your attention.
Thank you, Dr. Muntaha. Again, papers
I have a
open for
question.
questions.
Very nice presentation. So my question is, did you see in your study that is it impacting the overall survival? Because I guess there is a meta-analysis that's been published in 2016 stating that the extranodal extension in thyroid cancer has an impact on the recurrence, not the survival. But I'm interested to know about your data as well.
Sir, in my results, we looked into the time interval of recurrence in both the categories, which was approximately 2.5 years in both of them. So, looking into my limited number of patients, so we need more number of patients and a higher subset of data to comment on this. But in these subset, there was equal time of interval between recurrence in both the categories.
Thank you.
Any more questions? Yes.
Nice presentation. By looking at the results, I would like to ask that what do you think why this extranodal extension has not been added to the current guidelines, ATN and CCN? What is the reason behind? What do you think about it?
Thank you. When we thought about this, that why this important factor or we see is that as an important factor is not addressed into the guidelines, only one thing came to our mind that maybe because most of the guidelines are based on Western data and looking there, the patients usually, there is more awareness of the disease and the patients usually present earlier, and maybe this factor may not be an important factor in that population, but we, the population we belong to, and we see more and more of patients with this disease, and more of our patients have logistic issues. They usually present late. So this may be a factor that we see this factor as an important factor in our population. This could be one of the reasons, but.
And another thing, the patients with nodal mets are already treated as high-risk patients. So
No.
if we consider this factor of extranodal extension, what else we can offer them in terms of intensity of treatment or radioactive iodine, what else we can offer them?
So the nodal category is treated either as intermediate or as high risk. So the size of the node makes them high risk if it's more than 3 centimeter. So that is the point. So if we have like this factor incorporated, whether it's in the intermediate group or the high risk group, so we would have a standardized care of plan for these patients regarding whether to treat this particular subset.
Thank you.
Thank you.
Thank you. Okay, the next paper is entitled Laparoscopic versus Open Surgery for Advanced Stage Ovarian Cancer, a 10-year data analysis. This will be presented by Dr. Khayal Azam Khalil from Shaukat Khanum, Lahore.
Assalamualaikum. I'm Dr. Khayal Azam Khalil. I'm working as a fellow in gynecological oncology at Shaukat Khanum Hospital in Lahore. I will be talking about laparoscopic versus open surgery for advanced stage ovarian cancer. This is a 10-year data analysis. I don't have any conflict of interest to declare. Minimally invasive surgical approach has been incorporated in a vast majority of surgeries, including gynecological oncology. Many of our surgical colleagues are familiar with this technique. The laparoscopic surgical technique has proven over time to have superior postoperative outcomes compared to open surgery, including but not limited to recovery time, postoperative pain, and blood loss, to name a few. The treatment of advanced stage ovarian cancer includes neoadjuvant or adjuvant chemotherapy and debulking surgery. Laparoscopic surgical technique has been applied to oncological surgeries for several years with good outcomes. And laparoscopic surgical technique is also the most requested by patients as well. Reduced hospital stay and decreased pain management offsets any initial cost considerations. So the question is, when there are obvious benefits of laparoscopic surgery, why would we go back in time and look at laparoscopic and open surgery outcomes in ovarian cancer? The reason of which is that advanced stage ovarian cancer is essentially a peritoneal disease, so it can be anywhere and everywhere. and achieving R0 resection or complete gross resection or leaving less than 2 millimeter of tumor behind has proven survival benefit in ovarian cancer. So the question is whether we can achieve that with the minimally invasive technique. And the other consideration is the landmark LAC trial, which is comparing minimally invasive and abdominal radical hysterectomy in cervical cancer, and the results of which were that minimally invasive surgery had inferior survival outcomes, including overall and progression-free survival. So many gynecological oncologists, after these results, were cautious about the minimally invasive technique. So objective was to compare surgical outcomes, progression-free and overall survival in patients with laparoscopic versus open surgery for advanced stage ovarian cancer. This is a retrospective cross-sectional study. Data was collected from the Hospital Information System from January 2014 to January 2024, and it was conducted at the Department of Surgical Oncology at Shaukat Khanum Hospital, Lahore. 171 patients were found to be fulfilling the inclusion criteria, which was advanced stage 3, 4 ovarian cancer who underwent surgery. The exclusion criteria was early stage ovarian cancer, so stage 1 and 2 disease, BMI of more than 40, morbidly obese women, ECOG performance status of 3 or more than 3 actually, which is poor performance status at presentation. Women who did not undergo surgery were excluded for obvious reasons. And with more than one primary cancer had an impact on their survival outcomes. These were also excluded. Surgery for recurrent and residual disease, which is usually technically more difficult, were excluded, and patients who were lost to follow-up were also excluded. So our data cohort was divided based on surgical technique into open surgery and laparoscopy groups. Intraoperative and postoperative morbidity indicators and progression-free and overall survival were analyzed for both groups. Statistical analysis was done using the SPSS software version 27. Descriptive analysis were performed on all variables. And for overall and relapse-free survival, Kaplan-Meier analysis was performed. And for group-based comparisons, the log rank test was applied. So if you look at patient characteristics, the age, BMI, and ECOG performance status, none of the two groups have any statistical significant difference, which means that for patient characteristics, both groups were similar. The most common histology was high-grade serous ovarian cancer, which is historically the most commonly occurring ovarian cancer. In post-operative outcomes, estimated blood loss, hospital stay, neoadjuvant chemotherapy cycles, and length of surgery, the differences were all statistically significant, mentioned by the red arrows, and favorable for laparoscopic surgery except length of surgery. As we are a training institution, this was expected because most of the surgeries are being done along with teaching. The incidence of blood transfusion, ICU admission, and post-operative fever was low for the whole cohort, so these results did not reach its statistical significance. If we look at survival outcomes, for open and laparoscopic surgery, overall survival and recurrence-free survival, there was no difference, no statistically significant difference, as can be seen in the Kaplan-Meier curves. I wanted to talk about a few studies that have been done previously. The first one at the top, laparoscopy versus laparotomy for advanced stage ovarian cancer. This is a systematic review of previous studies that showed that both surgical techniques have equal oncological outcomes. Then the study on the bottom left is an overview of the current debate between using minimally invasive surgery versus laparotomy for interval cytoreductive surgery in epithelial ovarian cancer. This was done at Memorial Sloan Kettering Cancer Center in New York by Dr. Chi, who is a proponent of open surgery. And his conclusion was that more studies need to be conducted to find a definitive conclusion whether laparoscopy is or minimally invasive surgery is equivalent to laparotomy, and this includes robotic surgery. And the study on the bottom right is laparoscopic versus open debulking surgery for advanced epithelial ovarian cancer. This is a study similar to ours, a single center study, and they concluded that short-term post-operative outcomes were better for laparoscopic surgery and oncological outcomes are equal. So we concluded that laparoscopy offers short-term benefit in terms of intra and post-operative indicators, but no significant survival benefit was noted in one group over the other. For future considerations, there is an ongoing non-inferiority phase 3 trial currently enrolling patients to answer this question. And the primary endpoint is non-inferiority of disease-free survival in minimally invasive versus laparotomic interval debulking surgery. So we should be having an answer to this soon. I wanted to take this opportunity to make a special mention of Ms. Ahsan Khanum, who's our statistician, who's gone over the data with me a couple of times, and Dr. Ali Sayed for his unwavering support in teaching, research, and training throughout my fellowship. Thank you.
Thank you. If there are any questions, Dr. Tabinda.
Did we have a look at the residual disease in both arms? That what was the effect, minimal residual disease? Were we able to achieve R0 resection? And what was that impact on survival in both arms in these patients?
So all the patients that were in the cohort group had an R0 resection. So we considered the whole group of patients that we considered had complete gross resection, according to the surgical notes. Yes.
Thank you.
Anyone else? Okay, thank you very much.
Thank you.
Okay, and we come to our last talk now. This is entitled Absence of Constitutional MLH1 Promoter Methylation in Pakistani Colorectal Cancer Patients. This will be presented by Aisha Azim from Shaukat Khanum Memorial Cancer Hospital, Lahore.
Greetings to everyone. My name is Aisha Azim from Basic Science Research Department, Shaukat Khanum Memorial Cancer Hospital and Research Center. Today, I got the opportunity to present my research work that was mainly focused on screening of constitutional MLH1 promoter methylation in Pakistani colorectal cancer patients. I have no financial interest to declare. So, it is a well-documented fact that colorectal cancer is one of the most significant global health challenges, ranking third in incidence and second in mortality. It is also the fourth most common malignancy in Pakistan, with 8 standardized incidence and mortality rates of 5.4 and 3.1 respectively. Among many risk factors that lead to the development of colorectal cancer, genetic or epigenetic and environmental factors are important to discuss. Talking about genetic or epigenetic factors, the pathogenic variants in mismatched repair genes such as MLH1, MSS2, MSS6, and PMS2 are noteworthy, as they account for 1.8% of unselected colorectal cancer patients. Secondly, the promoter methylation of MMR genes can also lead to the development of colorectal cancer. Whereas low fiber diets, smoking, alcohol consumption, and lack of physical activity are among well-documented environmental factors. Before proceeding any further, we should understand the role of MMR gene in colorectal cancer. DNA replication is a well-known phenomenon. But sometimes during this process, chemical or physical damage may occur that may lead to DNA mismatch defect. Here, MMR genes come into action by activating DNA repair pathway and synthesis of MMR proteins and their dimers, resulting in cell survival. On the other hand, if there are pathogenic variants or methylation of MMR genes, the cell escape repair pathway, and there is no synthesis of MMR protein or their dimers, hence causing cancer. Moreover, among all MMR genes, the pathogenic variants in MLH1 gene are particularly important, as they account for 21.3% of genetically enriched colorectal cancer patients. Here is an interesting fact that some of CRC patients and some of CRC tumors lack MLH1 expression without even harboring any pathogenic variant in the gene. This implicates epigenetic modification, mainly promoter methylation. Here is an overview for the phenomena of promoter methylation. Suppose we have MLH1 gene here. The promoter encoding region of the gene can be shown in the picture. Under normal circumstances, the gene is transcribed into RNA and then translated into MLH1 protein. But if there is methylation of promoter region of the gene, the normal central dogma process is halted, and there is no synthesis of MLH1 protein. Talking about prevalence of MLH1 promoter methylation, most of the studies investigating the phenomena have focused on tumor tissues only, rather blood samples. So there is limited research on constitutional MLH1 promoter methylation, reporting 4.6 to 22% in unselected CRC and 0 to 27% in hereditary non-polyposis colorectal cancer or suspected HNPCC patients. There exist certain peculiarities in Pakistani population as well. For example, according to our previously published paper, Pakistani HNPCC and suspected HNPCC patients have higher prevalence of MLH1 and MSS2 pathogenic variants as compared to other Asian populations. Secondly, the mean age of CRC presentation is notably younger in Pakistan as compared to Western populations. Last but not the least, there is no data on constitutional MLH1 promoter methylation from Pakistan. This led us to design this study. So the objective of our study were to comprehensively investigate the prevalence of constitutional MLH1 promoter methylation in Pakistani colorectal cancer patients, and to explore if constitutional MLH1 promoter methylation could serve as an optimal, non-invasive epigenetic biomarker for early detection of colorectal cancer in Pakistan. For this study, we included 310 study participants. Of them, 210 were colorectal cancer patients and 100 were healthy controls. Colorectal cancer patients were further divided into two groups, HNPCC or suspected HNPCC and non-HNPCC group, comprising of 27 and 183 patients respectively. The criteria for the classification is mentioned here. For this study, we followed the methodology, including collection of blood sample from patients and healthy controls, genomic DNA extraction, quantification, and bisulfide modification. Then MLH1 promoter methylation screening through methylation-sensitive high-resolution melting assay, also known as MSHRM. Lastly, data analysis. Heading towards the results of the study, this table shows the characteristic and demographic characteristics of the study participants, including age at enrollment, gender, ethnicity, and MMR, particularly MLH1 pathogenic variant status. And we can see that 11 of our patients were MMR positive and 6 were particularly MLH1 positive. Heading towards methylation-specific high-resolution melting assay results, here are some facts that need to be discussed. That assay was performed in triplicates for each sample, and it was also validated through methylated and unmethylated standards. The quantity and integrity of the DNA was ensured through methylation-independent housekeeping MyoD gene. In this picture, we can see 3 different kinds of curves. The green one are for unmethylated samples grouped with unmethylated standard. The longer curve is for MyoD gene, and below them are methylated standards. In this study, we did not find any MLH1 promoter methylation in any of our patients as well as healthy controls. Talking about strengths, this is the first comprehensive study of its kind from Pakistan, and prior genetic testing for small range MMR pathogenic variants were also done for each patient. And assay was rigorously validated through methylation and unmethylation standards, and the DNA quantity and integrity was also ensured through methylation-independent MyoD gene. Here are some limitations as well. The methylation analysis was only performed on peripheral blood DNA, and no immunohistochemistry-based MLH1 expression and analysis on paired normal and tumor tissue was done. Our study concluded that constitutional MLH1 promoter methylation may not play a significant role in CRC predisposition in Pakistani population. Further investigations on paired blood and tumor tissues from MMR deficient and microsatellite instability high patients are warranted. So I would like to acknowledge all the study participants who participated in the study, the basic science research team and HOD of research department, Dr. Ahsan Rashid, and all the people who collaborated with us in the study. Lastly, we have also published this data this year in a well-reputed international journal, Gene Reports. Thank you.
If you could just wait in case there are any questions. And there are some questions, yes.
Assalamu alaikum. I have a basic question regarding your methodology, and that you used blood extracted DNA samples rather than taking tissue extracted DNA samples. Could you please elaborate the idea? Why did you choose the blood extracted DNA samples rather than taking tissue extracted? Whereas we consider that epigenetic modifications are more associated with the tissues rather than the germlines. Could you please?
Thank you for the question. That is an impressive question, I would say. So I've also mentioned in my study objective that we were looking for a non-invasive epigenetic biomarker for early detection of CRC. So taking blood sample from any person is less invasive as compared to tissue sample. So that's why we conducted this study, that we can find any non-invasive epigenetic modification that can lead us to the early detection of colorectal cancer. And that could only be blood sample. So that's why we conducted this study on blood samples.
Okay, and I have another question, that you used MyoD for your standard, like to have an internal control. There was a slide where I could see that MyoD has an expression in alignment with the methylated standards. What like if the MyoD gene was methylated, or if not?
No, MyoD gene is a housekeeping gene, and its promoter region is never methylated. That's why
But it was aligning with the
it is aligned with methylation because it has a continuous expression. So melt peak, if I can show you, the melt peak of MyoD gene aligns with methylated standards. This shows that the DNA sample that we have entered in the well of the assay, as if you know MSHRM assay, it shows that DNA is present and it is of high integrity, comparable to methylated standards. This validates our result, and this is the reason of mentioning that we validated this result through methylated and unmethylated standards along with methylation-independent MyoD gene.
Thank you. I think we need to go on to the next question. Thank you.
Nice presentation. I have a question. Other than blood and tissue sample, which kind of sample we can use to check the methylation pattern in CRC patient?
Okay. Thank you for the question. Saliva samples can also be used to study methylation pattern, but there is not an extensive research on saliva samples. So researchers basically prefer blood or tissue samples for this kind of studies, but saliva samples can also be used.
Thank you.
Thank you.
Okay, Aisha, I got a question for you. How did you classify colorectal patients as HNPCC and suspected HNPCC?
Okay, thank you. There is a stringent criteria for classification in HNPCC and suspected HNPCC group. For HNPCC, the patient should have at least 3 relatives with colorectal cancer, endometrial, small bowel, or urinary tract cancers. Whereas for suspected HNPCC, the patient should have only 1 relative with aforementioned cancers. So this is a stringent criteria mentioned in Amsterdam criteria.
Thank you.
Thank you. Thank you, everyone. I'd like to thank all the presenters. We now have about 10 minutes for the judges to collate their results and make up their minds, and in which time we will present some other awards. Okay, so we're going to start with awards for free papers. We had 8 sessions through the course of the 3 days of the symposium for free paper presentations. All papers that were presented were judged independently by a panel of 2 judges for each session. And the 3 papers that were judged the best in the oral presentation sessions, the authors will be invited up to receive an award for the free paper. So there are 3 awards for this. And I'd like to ask Ms. Rehana Elahi, Director of Nursing, to come up onto the stage to give these awards. as soon as she's up, we'll call up the authors. Yes. So the first of these is entitled Towards Overcoming Loss, Building Effective Bereavement Support Services in Tertiary Care Hospitals in Low and Middle Income Countries. And the author is Ahsan Rashid Kasana. Hold on. The next paper to be awarded is entitled Reflecting on Over a Decade of F18 FDG, PET-CT in Renal Cell Carcinoma. Is it time for more harmonized utilization? Sana Munir Gill from the Department of Nuclear Medicine. Congratulations, Dr. Sana. We can see the enthusiasm levels are high and rising rapidly. The third paper is entitled Clinical Manifestations, Antibiotic Sensitivity and Outcomes of Pneumococcal Infections in Oncological Patients, Insights from a Single Center Perspective. And this is to be awarded to Dr. Iraj Shehzad from the Department of Medicine. Thank you, Ms. Rehana. The next award is for a video session free paper. And I think many of you know that the hospital recently got official affirmation of our accreditation by the College of American Pathologists, or CAP. And so we would like to invite the hero of the hour, Dr. Mudassar Hussain, the head of pathology, to present this award. Absolutely. It's a surprise for everyone. Okay, so the award for the best video session free paper goes to Dr. Hadia Munir Beg for a presentation entitled Segmental Mandibulectomy and Reconstruction Using Fibula Free Flap. Great. Thank you. Okay, and then we also had e-posters. And there are 3 awards for the best e-posters, one for each of the 3 days. And for this, I'd like to invite Dr. Amna Khan, our senior most breast surgeon, to come up on the stage. Clearly a popular choice. So once Amna's up on the stage, then we'll start announcing those. Okay, so the best e-poster for day 1, the award goes to Imran Iftikhar, Management of Acute Lymphoblastic Leukemia During Pregnancy, a case report and review of the literature. I just realized it was slightly discourteous of me not to mention that the winner of the first award for the free paper, Ahsan Rashid Kasana, was from the Indus Hospital and Health Network, Karachi. The next award for best e-poster for day 2 goes to Fermín Fatima, immunogenicity development against adrenal cortex carcinoma by targeting PRKAR1A, ZNFR3, beta-catenin, and TP53 oncogenes, and design of a universal multi-epitope vaccine for 14 cancer types. I think there should be a small award for reading that out as well. Very well done. Thank you. And that was Dr. Fermín Fatma is from the University of Central Punjab, Lahore. Okay, and the last prize for best e-poster, and that's for today, day 3, goes to Saman Riaz for real-world data on the outcomes of upfront docetaxel in hormone-sensitive metastatic prostate cancer. And we're especially proud of Saman because she's come from Shaukat Khanum, Peshawar. Yes, 1, 2, 3. Who is the winner? It is 1, 1, 2. 1, 1, 2. Here will be 1. Thank you. Thank you, Amna. Okay, we're slowly getting to the Ahsan Rashid, but not quite yet. So the next prize is the Begum Mir Research Award. This is given to the highest ranked research presented in the nursing category in the symposium. The late Begum Mir was another very ardent and passionate supporter of Shaukat Khanum. She had a strong conviction with regard to providing free healthcare to poor and needy patients, and was particularly keen on promoting and enhancing the standards of nursing care in Pakistan. After she passed away, her family dedicated the construction and ongoing funding for the nursing teaching block at Shaukat Khanum Hospital in Lahore in memory of their mother, and that is today named the Begum Mahmooda Mir Nursing Institute. It was inaugurated in December 2002, and this award is given out to honor her memory. And I would like to invite Dr. Amir Ali, our senior most and longest serving oncological surgeon, to come up on the stage and give this award. So the Begum Mir Nursing Memorial Award goes to Hafiz Sibghatullah for a presentation entitled Health-Related Quality of Life and its Association with Perceived Social Support in Adult Breast Cancer Patients, a study from Karachi, Pakistan. Okay. Mr. Nasir Khan will accept the award on his behalf. Thank you, Ahmed. Okay, the next award is entitled the Bashir Alavi Award. This award was co-founded by Dr. Humayun Bashir and Professor Abbas Alavi. I think many people in the audience will know Dr. Humayun Bashir well. He was a resident, then a fellow, and then a consultant in our Department of Nuclear Medicine. Latterly, he was head of the Department of Nuclear Medicine. He now works as a consultant in nuclear medicine at the Kent and Canterbury Hospital in the United Kingdom. Professor Abbas Alavi is a world-renowned expert in nuclear medicine based in the US and was a plenary speaker at our symposium a few years ago. Dr. Humayun Bashir set this award up in memory of his late father, Ijaz Bashir. And the award is meant to acknowledge cancer research carried out in Pakistan Researchers, clinicians, and scientists from across the country are invited to submit their best publications for evaluation by a scientific committee of experts. We have Dr. Humayun Bashir's mother with us today. We're honored to have her amongst us, and she will give this award today. The award is to Noor Muhammad from the Department of Basic Sciences for his presentation entitled Contribution of Constitutional BRCA1 Promoter Methylation to Early Onset and Familial Breast Cancer Patients from Pakistan.
बहुत बहुत शुक्रिया आप सबका। मैं आपकी मशकूर हूँ कि आपने मुझे ये इज्जत बख्शी। थैंक यू।
आपका बहुत शुक्रिया। बहुत शुक्रिया आपके आने का और award का. Thank you. Oh, yeah. So we'll see how the judges are getting on. I think there's a tough contest out there.
So you're right. This one is number 5. Number 5. Yeah, we have the results. So we need number 1, number 2. So, we'll get, there's only one.
Okay, so we have the results of the Ahsan Rashid Award. And again, I'd like to thank all the audience, obviously, all the presenters. Especially, I'd like to thank the judges once more, Professor Muzaffar Kizilbash, Professor Jacek Gronwald, and Dr. Amna Hassan. Big hand for the judges. As you can see, they worked very hard to produce the results. So the third best paper in the Ahsan Rashid Memorial Session, we'll start, was Khayal Azam Khalil, laparoscopic surgery for advanced stage ovarian cancer. The second best paper was adjudged to be absence of constitutional MLH1 promoter methylation in colorectal cancer patients, Aisha Azim. And so there's only 4 papers left to choose from for the first prize. And I'd like to now invite Brigadier Naim up to the stage. As we mentioned, Brigadier Naim is the late Ahsan Rashid Saab's brother, and he will give this award. Sure, after the talk. Thanks. So Brigadier Naim is going to give the award for the Ahsan Rashid Memorial Medal this year for 2024. And the winner for 2024 is Mohammad Aves Kaval. Comparison of patient satisfaction in post-operative breast surgery patients with physical and telemedicine clinics. Congratulations to Dr. Aves. I think Brigadier Naim, we'd like to invite him to say a few words.
Assalamu alaikum. First of all, I would like to thank Dr. Asim Yusuf and the management of Shaukat Khanum for giving me the honor as younger brother of Mr. Ahsan Rashid to present this prestigious award. I would just say a few words about my brother Ahsan Rashid because many of you may not have met him, may not have known him, but his contributions made lot of difference and efforts in the construction of Shaukat Khanum Hospital. As a matter of fact, he started off with a small effort, and that was in the late 80s or maybe 1990. He arranged a small fair, a family fair, where all the family gathered. They put up stalls, and the fundraising for Shaukat Khanum was started here in Lahore. This many people don't know. And I still remember when Imran Khan was there, people just used to give him cash like this. And he was putting it in his pockets and they were flowing out. Then somebody came with a bag and started putting money. This is how it started. Then, as my brother was in Jeddah, and he was CEO of a company, he had good relations with the royal family also. So he put in a lot of efforts for fundraising for Shaukat Khanum Hospital. When my brother died, Imran Khan came on his funeral, and after that, he told me that there was a stage when the construction of Shaukat Khanum Hospital had practically stopped because there were no funds. So he said, I talked to your brother, Mr. Ahsan Rashid, and he put in, I don't know, so many efforts and gathered enough funds for the construction to restart. And then we see it is not one hospital, it is not two, it is now 3. MashaAllah. Ahsan Rashid, actually, he was a big humanitarian. And as Dr. Asim Yusuf said, he was a great benefactor of this hospital. But other than this hospital, he has also been doing a lot of humanitarian work while he was in Jeddah. From his own pocket, he opened schools for the people of the for the low-paid Pakistanis in Jeddah. This is also what he did. And when he developed cancer, he was told by many that he should go abroad. But he said, no, this is the hospital in which I have faith. So I will get myself treated from Shaukat Khanum Hospital, Lahore. When the time came and he left us, so in the end, I would just like to recite a small verse about him, which will explain his personality. सब कहाँ कुछ लाला गुल में नुमायां हो गईं, सब कहाँ कुछ लाला गुल में नुमायां हो गईं, खाक में क्या सूरतें होंगी कि पिन्हा हो गईं. और शेर ज़रा मुश्किल है. I will just try and make it easy. I got it from Google. They say this means that good people who do good deeds in this world, when they leave and they go in the dust, they keep blooming like flowers, like tulips and like roses. And this is actually what Ahsan Rashid was. Thank you so much for inviting me. And we're grateful. And yes, actually, Ahsan Rashid's wife is out of country, but his son, Mansoor Ahsan, can you please stand up? Mansoor. He is here also. Thank you so much.
Okay, so this brings the Shaukat Khanum Memorial Cancer Symposium for 2024 to its end. I'd like to thank all of you for being here, for presenting, for submitting your data. It's all of you that make the symposium what it is. We can plan ad nauseam, but if people don't submit research and don't come and attend the symposium, it's nothing in itself. So it's all of you that make the symposium a success. Please go out there and spread the word about this great scientific cancer meeting that we have every year. The dates for next year are this exact same weekend, but it'll be Friday the 24th, Saturday the 25th, and Sunday the 26th of October 2025. So, and it's in Lahore again. So we'll see you again in Lahore next year, inshallah. Thank you very much.